especially as women are going to the work as more as men. We always just remind ourselves that approximately 50% of patients with previous urinary calculi have the recurrent state within 10 years. So I warn my patients that if you develop a stone, you're more prone for another stone in around 50% within the coming 10 years. So you have to take your precautions.
بس دكتور انت
Yes,
بعدك على اول سلايد، انت يمكن صوت بالابديميولوجي صح؟ بس هو مش باين
بعدني
عندنا.
بالابيديولوجي.
احنا بعدنا عند اليوروثلايسيس بالعنوان.
اوكي، شو اسوي فيها؟
انه بس تأكد انه السلايدات تقلب. انت كبرت السلايدات ولا؟
كبرتهم، هي بقلبوا عندي.
عندنا لا.
عندك لا. طب shall I go again؟
هيك تمام.
هيك تمام. لما نعمل شو اسمه بتكون مش ظابطة، ليش بعرفش. اوكي
خلاص مش مشكلة.
خلص.
الصورة الصغيرة.
if that's clear it's okay.
clear enough. نعم.
Okay, so again the rate of urethritis increases with age. It's higher in men compared to women. حكينا ليش. And whites compared to this textbook talks. Whites compared to blacks and Hispanic and Asians are intermediate risk. وإحنا Hispanic وال Asians. It's estimated to be around 7 to 10 every 1,000 hospital admissions are due to stones. ونحن نعرف شو ال indications of admissions إن شاء الله خير. Epidemiological aspects for these urolithiasis, we have intrinsic factors and we have extrinsic factors. The intrinsic factors mainly depends on the age and sex, in addition to the hereditary, such as examples with patients with arterial renal tubular acidosis. They're more prone for episodes of urolithiasis, especially the both this are proximal, but the proximal more. Cystinuria is really a very bad stones or bad disease that may lead to renal stones. And with this cystinuria, just a quick reminder, the pathology is in the metabolism of cysteine, ornithine, lysine, and arginine, and usually it's in the liver. It's a homozygous recessive disease. When it comes to the age and sex, as we said, males more prone than females, and the peak age between the 3rd to the 5th decade of years of age. The intrinsic factors, diet, geography, climate, water intake, occupation, and the most important thing is what we ingest or what we eat. Purines, uric acids, oxalate or calcium, phosphate, and other elements. We will know it's not anymore like in the old days where we used to mention or warn the patients for dairy milks or calcium containing diets or milk. It's not valid anymore because we know that the precipitant factor is the oxalate and the endogenous calcium rather than the exogenous calcium. Geography, as we said, Asians and Hispanic or Europeans are in the middle class, while or in the middle of more prone countries for stones, like in modern countries or industrial countries. Climate and seasons, we know hot climates and summer climates, they're more prone for stones rather than usually in the winter, less urine production, less water intake. So you may develop a stone in the winter, but in the summer we may present more. Water intake, the more you ingest water, the better. This will lead to maybe be prone for stone disease. Occupation, we know that the indoor jobs sometimes, especially with less water intake, may carry a risk, and we know that physicians they are more prone for stones, our university teachers, and some the outdoor if they don't drink a lot and they work in hot climate. If you go to the types of the stones, we know that around 60 to 80% of stones are calcium containing stones. Either they are contain calcium oxalate or calcium phosphate, but we know that the calcium oxalate stones are more than the calcium phosphate. This is the types regarding the chemical composition. The 15-20%, around 1/5 of the stones are magnesium MAP stones, magnesium aluminum phosphate stones, or strovite stones, or infection stones, if we are talking about the causes. 5% they are uric acid stones, 1 to 3% is around is the rarest, which is around which is cysteine stones, and it's why it's 1 to 3%. There are some areas where there is a lot of consanguinity marriages. They have cysteine stones more than the others. In Jordan, we have a lot. In Jordan and Palestine, which is almost the same, we have a lot of niduses and family niduses within النكتشوية صغيرة في من جنين وفي من مثلا من الأربد العبيدات فرع منهم بيت السلطان لما يكون يقول أخي خاصرتي أو عنده دم بالبول إنه هي السيستين أو شيء السيستين until proven otherwise. برضو من جنين نفس الشيء we have a lot of family niduses. The same patient may have more than one type of stone concurrently, calcium and uric acid stones at the same time. If this is regarding the chemical composition, or sometimes we just divide them according to the radiology appearance, radio opaque or radiolucent. Radio opaque, we can see them on plain abdominal X-rays. Radiolucent, we don't see them in radio opaque stones. And roughly, would say that around 90% are calcium oxalate stone are radio opaque because they contain calcium and strovite stones, while uric acid stones are usually radiolucent and cysteine stones are semi-radio opaque. So sometimes we see them, sometimes we don't see them. When it comes to the etiology behind stone disease or behind the urolithiasis or the development or formation of stones, it's usually a collection of theories or a collection of risk factors. The first one is the supersaturation or cross-section theory, the matrix nucleation theory, inhibitor or absence theory, epitaxy, and combination of the above. And we will discuss all these in the coming few slides. So the formation, stone formation occurs when normally soluble materials such as calcium supersaturates in the urine and begins the process of crystallization. معناته اللي هي الذائب والمذيب. فمعناته لما يكون الذائب اللي هو مثلا على سبيل المثال زي الكالسيوم increase in concentration in the مذيب اللي هو اليورين, this will begins the process of crystallization. Crystallization per se it's harmless, but the crystals with anhydrous will form in a certain pH, so there will be an environment that will can I just take this phone from the hospital because they're running emergency.
تفضل تفضل.
يس مهند، انا على المحاضره مع الطلاب. مهند. هلا مهند. well done توكل على الله. اوكي انا بشوفه بس خلص مع الطلاب. شكرا. يسلمون عليكم. I am back. Can you hear me? شباب.
دكتور.
Okay, I'm back because they're running a torsion in the emergency in the hospital, so they just called me back about the result. الله عز وجل بأذن العصر. Again, so we just back crystallization and at a good environment, and we mean pH, which is the urine or the blood pH, whether this is alkaline or acidic. This will invite the epitaxy or matrix theory. What do you mean by epitaxy or matrix theory؟ زي ما يصير في عندكم انتم واحد epitaxis. epitaxis لما يكون واحد يعني يصير عنده شوية bleeding من النوز. Bleeding will invite more bleeding. So the idea is anidus, if there is a good environment where there is the solute is less, this will invite more crystals to come and connect together. In the presence of deficiency of inhibitors of stone formation, they will these will limit the stone aggregation and the growth. So if there's no inhibitors, crystallization will even crystals will even aggregate and stone will form. And you have to put on mind that citrate and magnesium are the most important inhibitors for stone formation. So it's presumed that crystals will aggregate, become large enough to be anchored, usually at the end of collecting ducts, and then slowly increase in size over the time and form stones with different sizes, and the sizes will will just have different presentations as we will see in the coming few slides, inshallah. There is multiple risk factors when it comes to the stone disease. The first one is a history of prior calcium chlorothiasis is usually a strong risk factor, and that's what we said at the beginning. You know, if I see a patient with a stone, I may warn him or her in that he is more prone to develop another stone in around 50% within 10 years. Family history of urothiasis, because of the, as we said, the congenital abnormalities, hereditary, as we insisting, or because they share the same environment. يعني أنا ساكن بيت مع أولادي، فأنا باكل نفس الأكل وبشرب نفس الأكل زي أولادي، فإذا I develop a stone أولادي ممكن they develop a stone. إذا باكل أنا وياهم كثير سبانخ وملوخية ومش عارف شو كنتين أو شوكولاتة، هاي اللي كنا قاعدين نعمل بالحضرة الحمد لله رب العالمين، وما زلنا الشوكولاتة عندي شو عم تنقطع. This may point for more oxalate stones or oxalate containing stones. أنا وعائلتي وزوجتي وبيتي وأنتوا وأبهاتكم وأمهاتكم. That's what we mean by family history of urothiasis. Dehydration and consequences: increased urine concentration, increased enteric absorption of oxalate, such as in patients with short bowel syndrome, where the main cause of this short bowel syndrome is either medical or surgical. Medical such as inflammatory bowel diseases زي ما كنتوا تعرفوا عن أو قرأتوا عن ulcerative colitis أو Crohn's disease, or surgical by surgical removal of part of the bowel. Urinary tract infection is sometimes a risk factor for stones, especially MAP stones. Medication that may promote crystalluria, such as sulfadiazine, trimethoprim, indovinir, and acetozolamide. And if you don't know these things, sulfadiazine, sometimes we use it for inflammatory bowel disease. Trimethoprim and indovinir, trimethoprim is an old drug that used to be used for either antibiotic and sometimes بدي منه الميgraine. Indovinir is an antiviral, and acetozolamide is a diuretic. Hypertension is also a risk factor that will increase hypercalciuria. Dietary habits: soft drinks acidified with phosphoric acid may increase the calcium stain formation with different drinks. Grapefruit and tomato juice increase the risk of stone disease because they contain oxalate more than the other risk factors. When it comes to special risk factors for uric acid stones, we know that gout or hyperuricemia or chronic diastasis, they are mainly 6 factors for uric acid stones. Fortified stones, urinary tract infection with urea splitting enzymes, organism such as Proteus, Klebsiella, E. coli. These are more stones. Cystinuria, inability, this is a congenital due instability of cystine in the urine. The major risk factors for stone disease. It's a long slide. Sorry, long slide and busy, and I don't think you can just read it. Hypercalciuria, hypocytraturia, low urine volume. All these are risk factors for most of the stones. But because we know calcium containing stones are more the commonest, which is around 60 to 80%. So it's rewritten again here. Dietary factors: low fluid intake, filtered drinks, apple or fruit juice may increase. High sodium chloride intake, high protein intake, low calcium intake may lead to developing a stone, because we know most of the calcium containing stones they have to combine either with calcium, with oxalate or phosphate. So calcium per cell itself is not really a risk factor. This is a predictive score for stone disease recurrence, where we give points for many risk factors or many history factors. It depends on the age, sex, urine volume, smoking, wine drinking, family history, stone number, and gouty arthritis history. So either from 0 to 3, like 0 to 4, it can calculate the predictive score and tell the patient about this. You don't really need to memorize all these things. These are just urological work. Now, for the stone disease itself, the most important thing is to diagnose that the patient is having a stone, and later on we will know that to diagnose the patient is having complications of a stone, which we will discuss inshallah كمان شوي. The most important thing is focus history, and usually when I meet you, and I always say whenever we deal with the patient with urinary lithiasis, or even the second part of the lecture, stone tumors, we have to ask about a past history of stone disease or passage or surgery, and the same thing, a family history of stone disease or passage or surgery, because they have liability to recurrence either in families or even in treatment. So focus history is important. family history, duration, variation of symptoms, signs. أحكي عنهم كان شوي عن الsymptoms, that is mainly renal pain. Clinical presentation, how the patient is presenting, whether this is just localized pain in the loin and you call this renal pain, راح نحكي عنه كمان شوي, or even urtic colic or edematous renal colic. Investigation, the most important thing is urine analysis, because the patients may present with hematuria, whether this is micro or macroscopic, and sometimes we go into more radiological tests, because we have to see, to diagnose the stone, you have to see it. You cannot diagnose the patient having stone on the basis of urine analysis per se or the symptoms. It's a combination, or you have to collect data, history, physical examination, and even investigations. So patient may present after already having passed gravel or stone. يعني ممكن يجيك وجايب لك حصوة معه، أو يقول لك كان عنده وجع or already passed. Usually small stones they can pass spontaneously, but sometimes they do not pass spontaneously, and they go from the pelvis into the ureter, and usually will give us the pain. Now, if the stone passes through the ureter, first of all, we have to quick reminder for you. We have two types of pain. We have localized and referred pain. The localized pain stays in its area or its organ or its origin, while referred pain goes to other places. It's not in the origin. Referred pain will be either shifting or radiation. The shifting pain starts from an area A, for example, and then disappears from area, goes to B. But in urology, in the tract, in the ureter, usually it's a hollow viscous, so it has a radiating pain. So it starts from A, goes to B at the same time. So if it stays in the kidney, mostly it will give us a renal pain. So it's a localized, continuous pain in the loin, and it is there all the time. But if the pain goes into the ureter, or the stone goes into the ureter, the pain will typically waxes and wane as the slide wax معناته يطلع وينزل in between the attacks, and we know it's caused by the contraction of the ureteric muscles, which is the ureteric peristalsis, and this is the ureteric colic. So it's a colicky pain, starts in a point, goes down because the ureter goes down from the kidney to the bladder, and caused by ureteric peristalsis or abnormal ureteric peristalsis, which is either ureteric spasm or even aggressive contraction. Usually, attacks are of severe pain, usually last between 20 to 60 minutes, and this is what we call ureteric colic. Now, if a patient having both, before we go to this, if you look at this slide, we can see the different areas of radiation, because upper ureter or lymphatic stones usually peristalsis from loin or flank to lower abdomen. Sometimes if you go down, it goes to the groin or the genitalia or even the thigh, and sometimes it goes to the tip of the urethra, depending on the area of involvement, whether this is intravesical part of the ureter or extravesical part of the ureter. And I don't think this is the scope of our talk today. المفروض نكون أخذتوا محاضرة عن البرزنتيشن إذا I have good knowledge of the curriculum. Anyhow, if you have any questions, we may make it at the end. Before we go into the slide, the third entity is called renal colic. Renal colic, as a quick reminder لإلكم, as you say, it's a misnomer or it's not a true colic. Yes, it's a combination of both the patients having renal pain and ureteric colic at the same time, either by a single pathology, single disease, or two different pathologies, two different diseases, one in the kidney and one in the ureter, and the patient is never back to zero. It works and wane, but never back to zero. So there is no free period in between the attacks. While in ureteric colic, yes, there is. Now, these are areas where we expect impactions of a stone in the kidney, usually in the pelvis, sorry, in the calyx, or before the calyx empties, because we know that the pelvis goes into the kidney through 2 to 3 major calyces. Each calyx will divide into 2 to 3 minor calyces. So the exit may sometimes be narrow physiologically, so a calyx may form a stone. A stone may form in the pelvis because of narrowing in the UPJ or PUJ junction, where the ureter goes into the pelvis. It crosses over the iliac vessels, and this is the pelvic brim. And the narrowest is the vesicoteric junction, and this is the narrowest and the most common because this is the narrowest area. This is just a slide where you can just look at the stone formation or stone location and the symptoms. Usually kidney stones, they present with vague loin pain. Vague, we call it dull, because the patient cannot describe the character of this pain. So either we call it dull or vague. And we have to know that flank can mean either loin or even lumbar. Sometimes hematuria, whether this is gross or microscopic. When it comes to the ureter, usually it's more severe pain. So it's a colicky pain, and sometimes also with nausea and vomiting because of the central innervation. Distal ureter intravesical part, intravesical, which is inside the bladder, may give us lower urinary tract symptoms such as frequency, hesitancy, or even dysuria. As we said, pain is a dysuria. If it was bladder, urinary bladder, poor stream, suprapubic pain, dysuria, urgency are usually the main presenting symptoms, either rotative or obstructive symptoms. And this is how we say this is a rotative manato dysuria, urgency, increased frequency, obstructive, poor stream, hesitancy, and distension. Now, the complication of the stone may present, patient may present with the complication of the stones, usually it's caused by renal obstruction. So the complication is either because of pain itself or obstruction that will give us sepsis and infection, fever, nephritis, and sometimes renal impairment or renal failure if patients having stones in bilateral pathologies or even single obstructive system. So renal failure is not a common presentation unless this is chronic or obstruction of bilateral obstruction or obstruction of a unilateral system. ماشي يا شباب. When it comes to the physical examination, usually the most important thing I always ask or tell the doctors, junior doctors, students, junior doctors, even senior, that we always start with vital signs. And the vital signs depends on the fever, heart rate, respiratory rate, and blood pressure. So if the patient is having any abnormality in the vital signs, especially fever, we think of infections. رين انجل تندرنس وبتهيألي بالجروبات اللي التقينا احنا وياهم حددنا كثير وين الرين انجل. And it's just a quick reminder, it's the meeting point between the lower rib, which the lowest rib, which is the 12th rib, and the erector spinae muscle, which is a muscle that's in the back. So this is the renal angle tenderness, where you put your thumb there and you know if there is tenderness or not, especially if the patient has the infection or even the extension of the capsule caused by hydronephrosis or even palpable kidney because of inflammation or enlarged kidney. Now, with the palpation, I have to look around that the patient is having palpable kidney or bladder. حكينا the kidneys, to feel a kidney normally it should be in a very thin patients and with the deep inspiration. وحكينا there's two techniques إذا تتذكر من رابعة أو من introductory course, sorry, and this is palpable or bimanual. And the bladder, we go to the suprapubic area and take from there. Sometimes we do some percussion over the suprapubic area to know whether this is fluid or this is gas because of the surrounding bowel. If you move quickly to the laboratory investigations, urine analysis is a must. It should be performed on all patients with suspected calculi, and even that present to urology clinic, whatever the complaint is, unless the complaint is originated rather than a urinary. يعني دائما انا باجي بنكد مشان تضحكوا شويه صغيره، بقول مستحيل حرامي يروح على صورتي يقول انا سرقت تحبسنيش، ومش منطقي يجيني مريض عيادة المسالك البوليه ومش فحص بول. Especially if the patient is having any urinary complaint. So, urine analysis should be performed. I look for microhematuria, for pH, whether this is acidic or alkaline, because we know that some stones they prefer acidic environment, some stones they prefer alkaline urine. Uric acid stones they prefer acidic urine, while infectious stones they prefer alkaline urine. So sometimes I may treat uric acid stones with alkalization of the urine and the other way around for the infection. I may see crystals and they are positive or they are important in cystine crystals. And sometimes if I'm thinking of infection, either superimposing infection or infection coexistence with stones, they, as we said, map stones, infectious stones, we can see them. Pyuria is fairly common response, irritation caused by stone and the absence of bacteria is not generally indicative of coexistence UTI. معناته يا شباب, this is what we call sterile pyuria. إذا كان في عندي واحد مريض عنده white blood cells in the urine, it does not mean all the time infection. معناته ممكن stone يعمل عندي infection, يعمل عندي white blood cells because of irritation, inflammation. Tumor ممكن يعمل عندي white blood cells in the urine. Glomerulonephritis ممكن يعمل عندي white blood cells in the urine. I think انه انتوا اخذتوا محاضره مع الدكتور عمر حلالشي عن infections and I hope انه it was covered there. I may ask for a kidney function test, especially the creatinine or the electrolytes, and I expect it to be impaired if there is a history of water loss or even fluid loss, either by nausea, vomiting, or there's no much water intake or chronic severe hematuria. With the CBC, I should always know why I'm asking for a test. We have to assess the white blood cells, looking for leukocytosis if I'm thinking of infection, and if the patient is having chronic anemia, this may affect his white blood cells. Now, if you go to the radiology, we have many radiological investigations. We start always with the simplest and the easiest, and the first one is a KUB or it's a plain abdominal X-ray, stands for kidney ureter bladder. There is no contrast. I cannot see the KUB. I can't see the kidney. This is a KUB. You cannot see anything. شايفين بس البياض تبع الربس. ان شاء الله بالريديولوجي هتعرفوا. وفي عندي some sort of whitish rounded structures in the area of the right kidney, because we know that the right kidney is behind, almost in the side of the abdomen, behind beneath the 12th rib والleft side نفس الشيء where we can there. Now if you go to KUB, back to slide, we know this is around 50% with a specificity around 70%. So I may miss around 50% of the stones, but if I can see a stone, I'm specific around 70%. It's accessible and expensive in all the hospitals and even urology centers. It's cheap, around 10 to 15 JD. It's not really very costly. It's sufficient to document the size and location of the stone, radio-opaque stones, but reduced stones can't be seen on a KUB. That's why it's around 50%. Sometimes, unfortunately, stones are obscured by stool or bowel gases. That's why I may ask the patient to for bowel preparation, or whenever I do the KUB, I ask specifically for KUB, not like abdominal X-ray, because I may give X-ray exposure more voltage to delineate what's back, because we know the tract is in the retroperitoneum. وإن شاء الله بتفهموها أكثر بزيادة لما تداوم الراديولوجي بسنة 5 وإن شاء الله تكون وجها لوجه. Sometimes it's not specific, because sometimes I may see a calcified mesenteric lymph node, gallstones, or even fluids in the pelvis, and I mix it with the stone. So it's not really specific. This is a KUB. You can see بعرفش إذا البوينتر بتشوفوه ولا لا. These are the vertebra, and this is the pelvic bone. But if you go to the right side, we can see bowel loop. This is the bowel loop, and there's two white structures in the area of the right kidney. We don't know whether these are stones or not. For delineation or better specificity, we go for other investigations. The easiest also, or the second is the ultrasound, with a sensitivity around 20% and a good specificity. So because the ultrasound is always man dependent or operator dependent. الناس يزعلوا عن البنات يقولوا أنا I'm a radiologist female. It's a radiology. It's an operator dependent. It's not a man dependent, because some females we have respected the female radiologists or radiographers. It's inaccessible in almost most of the centers, and even in the clinics of most of the doctors, whether they are urologists or non-urologists, because I call it it's our third hand. I have two hands to palpate and feel. My third hand is usually doing the ultrasound. It's easy in urology because we're looking for the kidneys, and they are just close by to big organs in the body. The right side close by to the liver, so if I localize the liver, I localize the kidney. And the left side, I localize the spleen, I can localize the left kidney. And if you go to the pelvis, so we cannot see the ureter. If you go to the pelvis, the only organ that normally contains fluid in the pelvis is the urinary bladder. We don't see fluids normally in the uterus or even in the bowel. They contain something else. Because if we see fluid in the uterus, it can be blood, and this is an emergency because of imperfect anus, or what we call hematocele, or ما يصير إن شاء الله طالما هي في سنة 5 أو بالgynecological. Usually it has a poor visualization with the stones, because we don't see the ureter unless it's hugely dilated. دائما بحكي للمريض اللي بقول لك في عندي حصه بالكيشف على الالتراساوند، بقول له يعني إذا كان dilated ممكن، أو يكون very lucky radiologist، أو this not very accurate، زي اللي بدور على إبرة بكومة قش. Usually we don't see stones in the ureter. Usually ultrasound is a procedure of choice for patients who should avoid radiation because there's no radiation, or we are scared of contrast giving to these patients, which are pregnant or women in the childbearing age. We don't give contrast, or even we don't go for contrast. We don't go for X-ray. Now, the third investigation, which is almost like now an old one, which is an IGP or IVU. IVP is intravenous pilogram, which is an English textbook, British, while if I'm reading from American textbooks, and into IVU, intravenous urogram, and you can see that the sensitivity around 70%, while the specificity around 90%. So I may lose stones, especially the radiolucent stones. في حدا فاتح سماعته بعرفش إذا بده يحكي أو يسأل ولا بالغلط. Okay, so it's relatively safe despite the need for a contrast. We have to give contrast. زي الKUB, we start the KUB and then we give contrast. And the contrast, as you see in the slide, we can see the ureter nicely draining. We can see going the whitish material now. It's going into the bladder, so it gives us anatomy of the tract. It provides the information about the obstruction, size and location, and the density of the stones, because we may decide what management or what mode of management can be used for or needed for that patient. Because we're giving contrast, we have to make sure that the patient is having normal creatinine, normal kidney function, because I may induce nephrotoxicity to that patient and I harm them. Now, patients with diabetes mellitus and glucophage we should be very careful regarding this. So we should stop glucophage at least for a period of 48 hours before doing the test or the IVU. These are just many or three IVUs just to delineate what's going on. And we're very lucky in urology that we also have, most of the times we have pairs, so we compare. فإذا بنروح على السلايد على السلايد right side, which is your left side, you can see two kidneys. إذا بتشوفوا الرايت kidney is almost اليوريتر فضة، البلدر مليانة، بس الليفت لسه مش عم بتفضي، معناته في عندي something wrong regarding this. بس إذا بتطلعوا على نفس الصورة على التب، دائما اليوريتر بيكون almost على التب with the transverse processes، نقدر نشوف في عندي زي راديو اوبيك ستون جاي بشكل طولي. And mostly later on we will discover this is a stone. So if you look at the other x-rays, you can see the contrast وقف على منطقة معناته على الأغلب إنه this were the obstructing area, and we can see that the stone is radio opaque and it's causing obstruction or not. تقول لي يا دكتور طب احنا مش شايفين اليوريتر كله مرة واحدة. Yes, we don't see the ureter as one line because of peristalsis. If we see the ureter كلياته مرة واحدة, this is completely wrong. But nowadays we go to the golden standard test or radiological test to diagnose stone. If we take any stone in the tract, we go for a non-contrast helical or spiral CT scan. It's fast, accurate, and identifies all the types of stones, whether radiopaque or radiolucent. Sensitivity goes to 100%, and even specificity goes to 100%. These just a little bit old figures, but nowadays it goes up to 100%. We don't give contrast، لأن الكونتراست يا شباب زي ما نعطيه بكون لونه أبيض زي ما شفتوا الأي فيو، والستون بين أبيض على أبيض معناته ضيناه. فسو we ask for a non-contrast helical or spiral. ليش helical or spiral؟ لأنه في عندي conventional CT scan، CT scan زي كات زي سياسات الجبنة. هلا helical or spiral بياخد cuts in between the cuts، يعني بيشوف زي ريكونستراكشن، وبكون الكاتس بدل ما يكون بين واحد والثاني نص سنتي او نبلشوا صار بين واحد والثاني 2 ملي، 2 ملي usually this is a very small stone. اذا كان في عندي 2 ملي ستون وما شفناه بين كات والثانيه، معناته this is not important، لانه The narrowest area, which is the vesicular junction, as we said previously, stone tuning can pass without symptoms. And one of the advantages of CT scan that can give us an information about other pathologies in the abdomen if there was other pathologies. These just CT scans you can see على الصورة اللي فوق right kidney في عندي radio picture زي almost بأبيض جايب almost على البلفس. بنفس الصورة جنبها تقدروا تشوفوا انه كيف عامل البلفس هون نص بالدايليتد، وبرضه هون عندي على راس الاسهم الصورة اليورين accumulating in the calyces so ecclesial system. الصورة اللي تحت مريض اجا with برضه يوريتريك شفنا باليوريتر لو تشوف على الصورة اللي تحت شمال السلايد اللي هو يمينكو في ارو بيقول لك انه dilated ureter مبين زي دائرة صغيرة. الصورة بعديها شفنا انه والله انه cause is a white structure in the middle of the dilated ureter close by to the bladder and this vesicular junction. So these without contrast. هذا نفس الشيء. هاي هون طلع يشوف كيف في عندي هاي هون البون بينه هاي هون مريض عم يعطي كونتراست. فمعناته يا شباب اذا نقارن شوفوا كيف شكل الاكس راي هون، كيف شكل الكدني هون بلش بين اكثر، معناته عم بيعطي مريض كونتراست. فاجى هلا هون ايش هذا ابيض اللي سواء كان بالكدني وباليوريتر، هذا ابيض because of a stone or because of a contrast we don't know. So that we say don't give contrast. Sometimes this is with IV contrast. بلش الكونتراست اوكي، بس هون we may guess اذا نطلع على الليفت سايد we compare left to right. اوكي الليفت اليوريتر شكله اكبر من الرايت، معناته شكله في عندي كونتراست جنب كونتراست، عامل كونتراست جنب ستون، ومبين عندي انه as one mass بس هي different material. So roughly if we go to diagnostic approach for these stones, if the history is suggestive, we ask for the simplest urinalysis and KUB. If the patient with or without hematuria, we treat for presumed peristalsis, urethriasis. If hematuria is present, is absent, or no stones, we can go other differential diagnosis, and you ask for a CT scan, and if CT scan is positive, we can go for urethriasis. So with the differential diagnosis of urethriasis, we always put in our mind, yes, shabab, in women in any gynecological process, ovarian torsion, ovarian cyst, ectopic pregnancy, and in men, in addition to women, GI pathologies, but in men more common, scrotal pathologies in boys. هذا المريض اللي فتحوه قبل هلا 14 سنة بالطوارئ، اجى على الطوارئ complaining of lower right iliac fossa pain، وشافوه الجراحة و they thought of appendicitis. فالفيزيكال اكزامينيشن ما كان عنده ريباوند تندرنس، ما كان عنده any low grade fever، ما كان عنده any signs of inflammation or appendicitis. So they did a CT scan for him, and the CT scan came back as normal. There is nothing wrong in the GI or the GU. So one of the doctors was smart enough to examine the child in the genitalia, and it was a torsion on the right side, referred pain into the abdomen, because we know يا شباب انه في شيء اسمه genitofemoral nerve. الجينيتوفيمورال نيرف من اسمه genitofemoral، معناته بده يكون في عندي genital branch وعندي femoral branch، هو نفسه الانرفيشن تبع الميدل بارت اوف ذا يوريتر. فمعناته ممكن يكون في عندي referred pain لليوريتر او لللور abdominal area رايت اللي يخصها، بس يكون الاوريجن من وين؟ من التستيكلز. هذا التورشن اللي فتحوه قبل شوي، ولكلي they could save the testis. It's an emergency surgery because an organ saving surgery. Anyhow, the other causes of abdominal pain زي ما حكينا appendicitis, cholecystitis, diverticulitis, colitis, constipation, hernias, all these may give us similar discomfort when it comes to the pain, whether it's in the right side or left side. Sometimes hematuria can be a mixing factor, and you have to know causes of hematuria, whether it's medical or surgical. وإن شاء الله رب العالمين بتاخدوها الأيام الجاية. هلا complication pathology changes, usually obstruction by calculus. This will lead to hydronephrosis. Hydronephrosis in the long run chronic will lead to atrophy and destruction of the renal parenchyma. Progressive and loss of renal parenchyma. This may, with superimposing infection, this may lead to renal impairment, and this is the what we really scared of. When it comes to the treatment, there's many factors that influence my choice treatment, but I think of treating the stone or treating the complications of the stone. Before we discuss this, we have to consider the economic status of the patient, whether he or she is insured or not, how much he's going or she's going to willing or going to pay or to cost him. Sometimes we know that CT is really expensive. I may go for a cheaper KUB or ultrasound. Duration of symptoms, usually the longer patient is having recurrent symptoms, is different from one that has just one attack of pain for 1 day. So I may consider this seriously, and the other one is not seriously. When it comes to the size of the stone, I expect more the figure around 4 millimeter. If the patient have a 4 millimeter stone, it's less likely to pass spontaneously. But I know some people, they pass even to 1 centimeter stone. So it depends on the status of whether this previous attacks or even this is gradual or the tolerability of pain without complications. If there's no movement of stone within 2 weeks, watchful waiting should be abandoned. I don't wait for more than 2 weeks. يعني إذا أنا متوقع إنه مريض عندي إجاني أبريوتك ستون وما 4 ملم أو 3 ملم وإجاني بعد أسبوعين بعده ما تنزل، معناته I don't think should watch or observe the patient. I should go for more aggressive treatment. Status of the opposite kidney pathology is always serious. Either the kidney is damaged or the patient is having impaired, or the patient is having comorbidities, diabetes, hypertension. I think that the kidney is not really normal, so I may reconsider my management. Age and condition, usually elderly, we do not go for anesthesia, so we just go for an invasive free anesthesia procedures. And a child, I just go with a minimum anesthesia because we know there's some risk factors to anesthesia in children. And I have to think about the area or the presence of obstruction or infection in these patients. Treating the infection is usually with antibiotic. Treating the obstruction is with relieving the obstruction, and treating the stone is get rid of the stone. Roughly, would say the acute therapy is IV hydration. If the patient is having loss of fluid, pain control, treating the complication of the stone, which is analgesia. The best thing is NSAIDs or ketorolac. If we can't give NSAIDs because of renal impairment, you're going to narcotics, mipridine اللي هو المورفين, أو pethidine أو المورفين, and these are the doses that we go. Sometimes we give antibiotics, but we don't give antibiotics at the acute stage or there's no fever. Some people talk about alpha blockers, and alpha blockers, يا شباب, the idea is they may lead to smooth muscle relaxation, and we know that the ureter has smooth muscles. This may facilitate the passage because of dilatation of the stone, and there is no more pain because there is no contraction. Usually, patients may manage at home if they are able to take oral medication and fluids. Hospitalization is required for patients who cannot tolerate oral intake or have severe pain or complicated conditions such as renal impairment, fever, obstruction of a single kidney, or bilateral pathologies. معناته يا شباب مش كل مريض بيجيني انا عنده ستون فوته otherwise ما بلاقيش مكان لأي مرض تاني سواء كان كورونا ولا غير كورونا. And sometimes, and usually ask the patient to stay in their urine and bring the stone. stay in their urine معناته انه يبول على شاشة او انه يراقب بوله. ممكن انه stone to pass, if it passes just get it back and you can send it for stone analysis to know what is the type of the stone for counseling for future recurrence. شو هذا مش عم بنزل السهم. اوكي شو هذا وين راح هيك. acute therapy repetition urgent procedure treatment لما يكون مع emergency اللي هي indication of admissions unremitting pain significant obstruction deterioration in function oliguria or anuria or associated infections زي ما حكينا قبل شوي. Some people they would ask okay يا دكتور whether this is first stone or recurrent stone. Patient with first stone usually symptom or symptom do not need metabolic evaluation other than serum calcium endorsed radiopaque stones and uric acid and reduced stones. We advise increase oral fluids, subsequent monitoring with a KUB ultrasound at 1 year, if negative, if 3 to 5 years, and stone analysis is preferred. But if the patient have recurrent stones, there should be a detailed metabolic and radiologic investigation trying to rule out شو صار. Okay, back to the next. There's to rule out either metabolic or anatomical causes as a cause for the stones. Metabolic workup usually indication for recurrent stones, pediatric age group, and bilateral stones. So a patient present with bilateral stones or pediatric age group less than 16 or 14 or 18 حسب قانون الدولة in Jordan 18 or recurrent stones. So we go for metabolic and sometimes we go for هاشم مرة ثانية. أي هاشم أنا محاضرة في إشي. هلا هاشم هلا. الله يعطيك العافية. ولدن. يا هاشم خليني أخلص محاضرتي مع الشباب وأحكي معك. بس الأمور ولدن يعطيكم العافية بدعتوا. شكرا. Sorry for this. I'm back. So indications with recurrent stone, pediatric stones, we go for metabolic evaluation. Usually we ask for even calcium, uric acid, citrate, oxalate, creatinine, pH, and sodium in the urine in inflammatory collection. And sometimes we ask for PTH, parathyroid hormone, and we ask for calcium, phosphorus, and uric acid in the serum. So we look for blood test and urine test to look for there. Now, sometimes we may suggest medical treatment as a prophylaxis for these stones. Usually for cancer stones, we may suggest combination of drugs. Sometimes the patient have calciuria, we may suggest thiazide. Hyperuricuriuria or gout or نقرس مرض الملوك. allopurinol. Sometimes we suggest potassium citrate for hypercetonuria if the patient is having hypercetonuria, and we may suggest potassium citrate. Uric acid stones, we may suggest potassium citrate, alkaline the urine, or allopurinol. As we said, cystine stones, the most important thing is high fluid intake, urine alkalization, and other drugs that may help in the recurrence. Usually, treatment of steroid stones is treating the infection in addition to other modalities of treating the stones, either by ESWL, extracorporeal security, or surgery. وإذا يعني كان في مجال يا شباب لكم انزلوا على ناقص واحد على وحدة تفتيت الحصى وشوفوا شو معنى اكسترا كوربوريشن سيكويرتي. عادة الناس بيقولوا تفتيت بالليزر. لا، اتس نوت ليزر، اتس تفتيت بالأشعة أو بالضرب الموجات الصادمة. يعني it's just an X-ray or waves that goes into the stone, make a vibration in the stone and break it. So it's not laser. it's shock wave. It's some waves lithotripsy. The other entity is شو عم بطير شو اسمه السلايدات اللي هي vesicular calculi. والvesicular calculi short can be primary formed in the bladder itself or secondary that's because of secondary causes to the bladder or they came from the upper tract and now they are down in the bladder.
حبيبي والله.
Sorry? مين حكى الفيولا؟ anyhow ما بعرف شو المشكلة. Okay, so usually they present with urinary tract symptoms, irritative and sometimes obstructive, and the treatment either with cystolithotripsy scopes or even with an open surgery cystolithotomy, and you have to treat the underlying cause. If you just look at this X-ray, you can see the patients having multiple urinary bladder stones, and we decided the treatment there. Sometimes it can be urethral calculi and can be either primary stricture or metal stenosis or secondary because of bladder or upper tract stones. Why it's not common in females? Because we know the female urethra is shorter and wider. And I never saw a patient with a female patient with urethral stone. Usually it passes okay with pain, but it doesn't get lost there. By this I don't want to go deeper بهاي المحاضرة. I think الساعة 3 يعني نقدر نقول 1 hour. بدكم تسألوا منيح، بدكم تسألوا، بتحبوا تريحوا لكم 10 دقايق، نرجع مرة ثانية على second part بصير، بتحبوا أكمل بصير. The floor is open for suggestions.
ما في مشكلة دكتور، إذا كمل مباشرة عادي، أو إذا بدك تحكي تلفون تخلص وبعدين ترجع لنا برضه بصير.
لا بخلص شو اسمه زي ما بدكم انتم. فيش عندكم اسئله؟ معناته واحد من اثنين، يا اما المحاضره ممله، يا اما مش عاملين اشي، يا اما شو اسمه